Sorry about the vehement, I'm talking about benzodiazepines today, but I also am one of the few buprenorphine prescribers for the Wake Forest Health System. And we recently have looked into the laws, and fortunately the FDA director has come out this week and showing and indicating that when you're using naloxone, you should also then offer buprenorphine, because this is something that we can do in our hospitals. We do offer methadone for our patients, and it's been this what's in the law, but any provider with a DEA can provide as much narcotic and much opiate as they want. We are limited to how many patients we can prescribe if we are treating opiate use disorder on the outpatient, but not on the inpatient setting. So we can prescribe buprenorphine and methadone in the hospital. And the real issue is, once they're started in the hospital, how many of you all, or how many providers can we get the DEAX? Because I, as a psychiatrist, have a DEA and can prescribe unlimited opiates. But I can only care for 100 in my first year, and 275 in my career. And buprenorphine is a safer, effective pain medicine, so it's been FDA approved for pain, and it is not associated with as many overdoses because it has a respiratory depression ceiling. So when we show and talk about our benzodiazepines today, the opiate overdoses and buprenorphine overdoses are in a combination with benzodiazepines and other CNS depressants, so including alcohol. We haven't had that discussion here, but if you are an opiate user, you often use alcohol and benzodiazepines. And so it's the combination of all of these things that we need to educate our patients. So to begin with, I'm talking about benzodiazepines and Z drugs, about the misuse, abuse, and dependence. Because this problem coincides and travels along with, and you'll hear from Dr. Brown later, about the more common use of alcohol and the problems associated with alcohol, because we're really talking about the abuse and misuse and dependence on all of these drugs. So key points today, we'll be discussing the daily use of benzodiazepines as equal to being risky. There is a decline in the use of benzodiazepines over time across the lifetime, but still about 15% of Americans report that they've taken a benzodiazepine or a hypnotic drug in the last year. Certain situations increase the risk for benzodiazepine problems, including our prescription practices, so I'll be talking about that. The medication characteristics, because we as providers have selection of many benzodiazepines, and we can choose safer ones. And then patient characteristics, like previous speakers have noted. What we want patients and families and all of the community to do is to expect dependence and withdrawal when we use medications for more than 2 weeks. If it's an opiate, if it's a benzodiazepine, if it's a hypnotic, we need people to expect that there may be dependence and withdrawal. So the advice is to taper benzodiazepines slowly if daily use is more than 2 weeks. So the providers are part of us, but you as individuals could also be family members. I know someone had mentioned a family. And you are part of our community. We need you to learn that we should all discuss and document and then quiz back our family members and our patients about the expected risks that include death. So we need to optimize, not just prescribe something, but optimize the behavioral treatments. Many of them are available on your phone on an app. Deep breathing helps with anxiety. By the age of 11, young girls go from being thoracic or diaphragmatic breathers to thoracic breathers. to hold their tummies in to look more like Barbies. If you're a thoracic breather, you're more likely to have anxiety. If you're having a panic attack, people breathe very rapidly. You slow them down and breathe 4 breaths a minute. That really helps with anxiety. How many of you knew that? It's a very common sense. It takes 1 minute or less to teach a person to inhale to the maximum of event. So I'm going to have you do it. The Om sign, universal Om sign, is when you take your fingers and you're holding your favorite leaf. So mine is rosemary. Not too tight and not loose, but your favorite leaf. And now what I'd like to have you do is inhale to the maximum. Like really inhale and see if you can count between 15 and 20 seconds. Ready? That expands one of the biggest muscles in your body called the diaphragm. And the diaphragm is innervated by the vagal nerve. And if you have incredibly anxious patients and teach them this, they instantly feel better, and it's probably related to the vagal nerve. So just teaching people deep breathing, relaxation, that they need 150 minutes of fun fitness a week. They're like, fun? But yes, it has to be fun or otherwise you won't do it. And that level of moderate to vigorous activity improves your cognition. Endorphins are the best anxiety drug ever. And if it's fun, you do it with other people. Fun family fitness, fun fitness with friends. These are all things that help with anxiety. And we also know it helps with healthy brain aging. You get new brain cells if you do 150 minutes. So can we talk to them about sleep hygiene? The average family has like 10 screens in their bedroom. Blue light stimulates your brain. It's like wake-up light. So we have to get them to just move their screens out. And then really over-the-counter medications. We have a researcher at Wake Forest now that says mindfulness, it may be as effective and more effective for pain control than opiates, Zidane. So can we teach them yoga? Can we use healing touch? We have a new center for integrated medicine with Remy Cotreau, a new clinic where you can be treated with healing touch and have a comprehensive evaluation that includes options including acupuncture and EMDR. These are all should be offered before pain medicines and benzodiazepines. So then we can talk to them about how we're going to try to limit and have it be episodic. How many of you go to a primary care doctor that you've been seeing for 10 years? Raise your hand. How many for 5 years? How many for 1 year? And really what we see is in our clinics, we train residents, they switch every year. And so they don't see the continuity. And what happens in our clinic, Dr. Lord said, that if you start a benzodiazepine and have a trouble getting off, then they want to send them to psychiatry. It's way easier to start a drug than it is to stop it. If we start it with the expectation that we want to avoid problems and avoid risks and use the lowest dose to improve function, not necessarily to take anxiety totally away. The idea that we're going to take anxiety and can we give them the shortest exposure to avoid risk of dependence, abuse, and withdrawal? Also for them to understand that we have to taper occasionally to avoid the chronic administration. And in the CDC guidelines for pain, it's over 3 months. We need to always assess depression, suicidal ideation, and treat comorbid conditions because we have talked about pain and depression and how common these travel. We do now know that there's some data came out this year that benzodiazepine alone and hypnotics alone increase the risk for suicide. Is it because the insomnia, even true and unrelated, but the data is clear that just because you're putting somebody on these medications, then they're more likely to have problems with suicide. So when I went to medical school, benzodiazepine receptor was something basic. It's changing every year. We know more and more and more. It's more complicated. So I just challenge you to read and keep up, because it's not just benzodiazepines and the Z drugs. Now doxepin and other sedative medications can also increase your risk for suicide. So we need to know that it's not just GABA and it's not just benzodiazepines. So what are they? We have more sedative hypnotic drugs, flurazepam, temazepam, and triazolam. These are older drugs, so most people don't use them. And we have anxiolytics, alprazolam, chlordiazepoxide, clonazepam, and diazepam. We have the non-related Z drugs, Zolpidem being the most common. And we all know that there are adverse effects. You can slow your reaction time, especially in combination with other sedative hypnotics, including alcohol and opiates. You can have cognitive impairment, sedation, amnesia. And these go up over the age of 65 with alcohol, opiate use, and the use of more than one. People are like, why would you use more than one? I had a gentleman who came into our clinic. He was brought in because his wife was worried that he was impaired, and they were worried that he was getting demented. We talked to him, and he has chronic pain. And we calculated on how many different opiates he was on. There were 4. He was on over 400 morphine milliequivalents. And he was on 3 different benzodiazepines and sedative hypnotics. And 2 sedative, antidepressant, and antipsychotics. And his wife said that he shot the TV. And I said, well, the good news is, I think we can do something about the impairment, the cognitive impairment here. She goes, well, now I just let him use the gun outside. I said, well, the bad news is we're going to have to let you not use the gun at all until we get this under control. Not to mention the car keys, because he'd already wrecked the car twice. And so we don't understand the additive effect, and the average older person is on more than 8 medicines, and people are not adding up the morphine milliequivalents or the benzodiazepine milliequivalents or milligrams. So we also know that there is an increased risk with how lipophilic a benzodiazepine is. So the faster the onset, the faster it goes into your CNS, the more likely it's to be abused, including alprazolam and diazepam. That was not what they marketed when they first released alprazolam. So the misuse is this question about long-term use and non-medical use, using your friend's medicine when you get on the airplane to fly to Europe. The abuse really occurs with problems when you have dysfunction in one area. And dependence is 3 or more of 7 criteria, but it really, the physical dependence is a very problematic one, because in benzodiazepine withdrawal, there are risks for seizures. And if you have a seizure while you're in the car or hiking over a tall bridge, there are life-threatening circumstances. So we really need to have people be aware that you need to taper slowly. And then there is a small group of people who have compulsive use and loss of control. So we don't really need to over-represent the misuse and medication factors, but we need to be aware of it so that everybody understands why their doctors are trying to be careful about this rather than, get out of my office. You want to really make sure that you pay attention to more than 2 weeks of these medications. And in particular, alprazolam is my least favorite benzodiazepine. My residents probably get tired of me saying that. In particular, this drug is very hard to get off of compared to every other benzodiazepine. So even when we switch them to longer acting medications, which are indicated, they all really want to go back to the alprazolam. I've had professors, shave it off with a razor blade, the dose of alprazolam. So if you are going to start a benzodiazepine, alprazolam is the one to avoid. And then avoid, if we can, alprazolam and diazepam. And the slowest absorption and lowest abuse is the least used. It's Oxazepam or Syrax. I like Oxazepam because it has no active metabolites, no accumulation, slow intestinal absorption, rate of onset, it helps, but it's not forever. And the metabolism doesn't change with age or mild to moderate liver disease, which is often something that we're worried about. It's eliminated by your kidneys. Out the liver, Oxazepam, lorazepam, and temazepam. Most people just use lorazepam. So the patient factors where misuse is more common are the substance use disorders with a current history, anybody with a psychiatric disorder, and certain social and demographic factors, although with benzodiazepines it's very common across all socioeconomic and demographic regions. Benzos and alcohol we know put you at risk. And then if you add any other sedative drug, that puts you at great risk. And then particularly benzos and opioids. We know anxiety and depression travel together, so let's treat it. Treat it with an antidepressant. Treat it with other anxiolytics like buspirone that are not as fast onset, but they still work. And then can we pay attention to the age, gender, unemployment, and poor social support and address that rather than think that a medicine or a pill is going to help with everything. So the bottom line of my talk is let's taper these drugs slowly. You can use 2 to 4 doses or switch to a long-acting chlordiazepoxide or diazepam and taper about 25% every 3 days. And then in the last half, go slowly. These are medicines that people either behaviorally or pharmacologically, that it's a slow taper. But if they do all of the other behavioral things, they notice an improvement in their function. They notice an improvement in their cognition. And they notice the positive. If you go slowly, people begin to notice the positive. Melatonin may help with the taper, as do other medications like gabapentin and carbamazepine. We really do need to always remember to provide that support. I know I sound like a broken record, but include all of the things we've talked about and engage close family members. Family members, don't you want to teach them not to be a nag, but to notice positive things and notice how to get them to do fun things. So do the deep breathing and mindfulness and yoga together. So in summary, it's really the long-term use that we need to pay attention to. Pay attention to and expect side effects and really minimize any risk from misuse, dependence, and use disorders from the start. We saw a slide that there are 7 million prescriptions in the North Carolina for opiates. I have no idea how many there are for benzos. So it's just the new starts that we're talking about, but then how do you deal with the people who are on it? You have to get them to agree to a mutual purpose. Do they want to improve their function? Do they want to think more clearly and live more healthily? Do they notice that they're having troubles concentrating or forgetting things? And it's a really good key, no pun intended, to say, how many times do you lose your keys? Almost everybody loses their keys. Don't tell them that's my trick, but But you can help somebody think, well, maybe if you go down on your benzodiazepines and go off of it, you'll be able to concentrate better, and you'll be able to do these if you practice mindfulness, practice deep breathing, and then you won't lose your keys. So, thank you very much. Oh, yeah. Thank you very much. So I have some other time, it looks like. Yeah.
What's your opinion? I've seen things like the opinion and evidence on the risks of benzodiazepines in older people on cognitive function and falls, dementia risk.
Well, the question is, what is the risk for cognitive function and falls in older people? I think the data is clear. They don't help. And so anxiety in itself doesn't cause falls. And sort of how do we optimize somebody? And if that is an issue, it's an indication that you wouldn't want to try that first, second, or third. Or if it's something that they're on, we might want to taper off.
What dose of melatonin do you use?
I don't personally use melatonin because it's not regulated. What's the dose of melatonin and do I use it? So I personally don't use melatonin unless, and maybe somebody in the audience knows, if someone voluntarily submitted, the company voluntarily submits what's in the product. Because there are studies, we have the plant genome has been genotyped, and they take the products off the counter randomly and test them. Less than a third of those products have what's on the label, even an infinitesimal amount. And some of them actually have toxic weeds from India that cause diarrhea and headaches. And tryptophan, when I was in medical school, came out unregulated, like the $10 billion industry we have now. And there were toxic effects with tryptophan that caused eosinophilia. And so I can't really, because it's not safe, I can't safely say that this is safe. So that's not something that I recommend. But I know people really like melatonin and take it all the time.
I came up from Florida. I'm sorry that you're all jealous about that. But I'm visiting family as well. There's talk in Florida about them regulating or making gabapentin controlled substances because of misuse. So I didn't know about North Carolina. I just wanted to know maybe your opinion or feelings. And you mentioned it several times in your slide about using it. How would that affect you moving forward?
I would be surprised if it becomes regulated, in that it is first FDA approved for seizures, and neurologists use it widely. And so the abuse potential of gabapentin compared to benzodiazepine, so on the tier of problematic drugs, that's sort of lower. But I have heard that from our community providers that patients like it. And, you know, it's not a bad drug to like if it prevents seizures, right?
When you were talking of Oxazepam, you also mentioned Lorazepam, and I missed what relationship you were...
There are 3 drugs that are not metabolized by the liver. OTL, or out the liver. OLT, that's what the medical students, the mantra is. So it's Oxazepam, Lorazepam, and Temazepam. So in an alcoholic, those are drugs that we would like to use. And Oxazepam being nice because it doesn't have any metabolites.
So on that note, that's clinically, if you look at prescription use, Oxazepam pretty low. Clonazepam tends to be, it's longer acting, it's better to wean off. So clinically, Oxazepam is actually, probably in the psychiatry world, it's used more, but in the primary care world, if you look at prescription use, it's very low. Can you comment on that?
I don't understand it. Only out of habit. Out of habit, you prescribe what other people prescribe. And And so when you have professors who say alprazolam is the drug of choice for anxiety, then it's hard.
But I think there's actually literature that promotes the long action of Klonopin, clonazepam, for lots of different reasons than the benzo.
I think in long-term use. So you're correct when you're starting somebody. When you have somebody on a drug and they need it, a longer half-life and a longer metabolite is always good. So the literature is different because one of the reasons alprazolam is so difficult is you could have interdose anxiety. And how is that any different than the underlying anxiety?
As you were talking about first behavior treatments and talking about things like deep breathing, mindfulness, and so forth, I didn't see anything mentioned about aromatherapy. Can you speak on that?
I don't know much about it, but I like the thought of it. I also realized that I failed to add outdoor therapy. Sunshine and being outside in a safe neighborhood. When I practiced at Penn in West Philly, it wasn't safe to go outside, so we had to get them to the parks. But the idea of finding a place and listening to the music of the frogs, the birds, sitting on your porch, really creating a spa-like effect. And people like the idea of creating a spa-like effect, and then they show me pictures of their bedrooms. This is not comfortable. So sleep hygiene is to only sleep and have sex in your room. And everything else out. You mean I can't read in bed? No TV, no, and that's heresy to get the big flat screen TV out where they can't fall asleep to it. But if they have insomnia, that may be the part of the reason. So, aromatherapy I like. Lavender, they make these infused pillows that you can microwave and put on your eyes, and they're on sale right now for the holidays.
Pain management, we always see a lot of muscle relaxers.
Mm-hmm.
Where does this fit in the scheme?
I think
Please repeat the question.
the pain management, we also see muscle relaxants. And that speaks to this polypharmacy, multiple things. And so rather than keep adding multiple things, I prefer muscle relaxants to opioids. But opioids are very good medicines. I'm married to a surgeon who takes prostates, kidneys, and bladders out with no opiate anesthesia now at Wake Forest for 5 years. So there are better drugs than opiates for pain, including ketamine, propofol. If you've ever had a colonoscopy, we do not use opiates for that. We use propofol. So the combinations of medicines now to get us around. So we have a group at Baptist who are motivated, even in the operating room and post-op, to moving people away from opiates and using buprenorphine for pain. So our chronic pain team this year, I've convinced them because it's FDA approved for pain first before it was for opiates, to begin to use it. So when you have cognitive problems above 50 or above 100, or this gentleman that we had who was 400, buprenorphine can be used safely. And it really has pain at a 15-to-1 ratio to morphine. So it has a very nice pain, but it's not perfect. So that everybody's always worried, well, what if it's not enough? In chronic pain, I'm not worried about it not being enough. But it's not widely used. And we have to prescribe the current products that we have off-label, except for the patch. So it is, Butrans patch is FDA approved, but it's very expensive.
Are there situations where you would recommend prescribing one patient two different benzodiazepines?
I I don't think so, unless they were going to have a procedure. They were on a long-acting benzodiazepine and needed midazolam. I don't understand why there would be. Would I ever prescribe more than one? Would you? Either of you? Peja?
No.
I think it's a good question. And I don't really understand the pharmacology or the science behind needing more than one, either benzodiazepine, or when we see people who are on Flexeril, OxyContin, hydromorphone, and MS-Contin, that doesn't make sense to me. You should streamline and have one. And the CDC guidelines are really great in pointing out we really have no data that it works for more than 6 weeks to 3 months. They're not that great at pain medicine, pain control, and they cause enormous problems, including constipation. A lot of chronic illnesses are related to constipation. And most people don't even ask about it. So I think when we have the discussion about chronic exposure to any of these compounds, including alcohol, one of the questions is, what are the benefits, and do they outweigh the risks? The slide deck that I was talking from is not the current deck, but that's okay. The ones that are in my, that you'll receive, have New England Journal articles and really talk about what are the risks associated with each of the different kinds of drugs, because we have a recent paper that came out. And it really gets us to think about reading and keeping up. The more we read, the more we know. The more we know that these are not the safest drugs. Now that we know it, how do we back out of a problem and prevent the forward process, go prospectively? How do we do a better job? And we're at a crisis, and I am an addiction psychiatrist, and I say never waste a crisis, because the problems with nicotine and alcohol are bigger. The death from opiates is tragic. Everybody's telling me somebody in their family member has it. And how many of you here have either benzodiazepines or opiates in your cabinet? This is an unusual audience. Good for you. That is really because most of the exposure is coming through our kids. Pill parties, going in, you're not going to miss a couple pills here or a couple there. They take them to the parties and they dump them in a bowl, and they'll take hydrochlorothiazide and propranolol with benzodiazepines and opiates. So when they come into the ER, they're very sick. And we really don't know what's going on. And it really is. My mom recently died of cancer, and we went into her medicine cabinet, and it was 25 years of prescriptions. It was a boatload, and I wished we'd had the disposal boxes that we have at Wake Forest, but this is in Colorado in a rural community. So you mix it either with kitty litter or coffee grounds. You don't want to pour it, even though sometimes you'll read on the internet to just flush it and put it down the sink, but inactivate it in some way, either with kitty litter or coffee grounds.
So I'm a pharmacist, and we've had people come in asking where they can get rid of all of their medicines that they're not using anymore. So Wake Forest, anyone can come to Baptist, to the hospital, and ask where is the drug from.
Any of our pharmacies have them. They're big boxes now. It's like a mailbox. You just put them in there, which, I think we should have.
In some of them, you can go to the sheriff's office, and take the label off.
I have heard that fire stations and police will take them too, but I can't, it just depends on the neighborhood. I wish more people used them. We did a study with our public health people, and less than 0.3% of prescriptions are turned back. So that's why the NC Stop Act is going to actually help us.
In Stubbs County, they've actually had a pretty good return. They have had, there's a coalition that is looking at that. The sheriff's office in Danbury, police department in King, and the sheriff's substation in Yaletote will have permanent boxes. And then the coalition will come out to public events with their incinerator and will take back meds. And, and they've taken back hundreds of thousands of doses of it. So.
Because it's not necessarily just your kids, it's the babysitters. And then, like the member who mentioned the kids of the grandparents, they become targets. And it really is the palliative care people who get big prescriptions and we don't know if they're actually taking them or not, or if they're diverted. So.
I have a question concerning the alternative therapies that you suggest as far as mindfulness, deep breathing, yoga, EMDR, before you prescribe anything. I think in a rural setting, as most of North Carolina is, the accessibility of those communities, I don't see that as being opportunities in a rural setting, because it takes people to educate and continue that type of treatment. I mean, I agree with you, but I don't see the accessibility there. Could you comment on that?
I think that's a brilliant question. And most people have phones now. So how do we, as providers and as community members, find positive apps and positive things that work? And then how do we move into the places where people do come together, like churches, to pain management clinics? Can we provide mindfulness groups there? So we have a pregnant buprenorphine clinic, and we have buprenorphine, and they do groups. But we next week are starting a pain group. And we're going to provide mindfulness training and healing touch and have the providers in the alternative care clinic come teach us. And I know that we can come out and teach you in rural North Carolina too, and that's what we need to do. I was like, one of the women who wants to run the groups is a yoga girl, or lady. She's very good. And she says, but I can't practice yoga. And I said, but you could still teach deep breathing and demonstrate for people what the benefit is. And you can do yoga online. I mean, see the positions and do it in your own home.
I was just going to say, I live in a very rural area in Moxley, but sometimes I think that's a better place to get out and breathe, walk through the woods, and the local Ys offer yoga.
Ys are one of my favorite places because they also offer sliding scales. So it's a community, and you can do mindfulness in groups, and then they have, other social events. So a lot of people who are in pain and who are isolated, just to get your mind off of things, just going to sit. Sometimes I get my older patients to just go sit and have coffee. The free coffee at the Robin Hood Y stops at noon, they tell me. But, that's how do we get them to think outside of, it's just a pill and I want the pill to go away, take everything away. I want my Dilaudid. Versus, have you tried all these other things? Let's try stretching. So I think, and I did not put this on my book, or on my topic, but I'll have it in the slides. One of my favorite things for pain is the Robin McKenzie book. Physical therapist from Australia, and it's 7 Steps to Pain-Free Back and Neck. It's $1 on Amazon used. But it's really good anatomy for acute pain and chronic pain of the back. And it has prevention exercises in there to strengthen your paraspinal muscles, to keep your discs in place, because all of us are hunched down and we are predisposed to having lower back pain. And if we teach our patients these exercises, which take 2 minutes, I do them twice a day, you can prevent a lot of back pain. And we really have data that shows surgery and opiates are not good for back pain. So we have to move to these exercises, and they're free to do every day. So rather than prescribing that, I always prescribe the book. Ibuprofen, non-steroidals, because ibuprofen and Tylenol work at different receptors of acetaminophen, so you can alternate with both of them.
What's the name of the book again?
Robin McKenzie, Mckenzie, 7 Steps to Pain-Free Living, and he wrote one on back and neck, but just by the combination book, it's back and neck. And literally the other exercises, if you have acute back pain, what to do, and it works. Because my husband is a surgeon and he threw his back out, and we were out somewhere far away. He goes, okay, I'll try your book exercise. Down he went, the pain went away. So that's anecdotal, but I have hundreds of people who use it. We found it from the University of Chicago Physical Therapy. His partner threw his back out, so widely recommended.
I have a roughly 50-year-old patient. I'm in a rural family medicine. She's been depending on Xanax for over 20 years. She is uninsured and was willing and motivated to try. Are we going to get anywhere with that?
I think we have more than our fair share of these exact people. And I do try. And I try everything. So I go through the line of trying to switch them to clonazepam, trying to switch them to diazepam, trying to switch them to chlordiazepoxide, saying alprazolam is way harder to get off. And can we get you one that's not as good, but you can tolerate it? And then slowly go down. So if they stay with you, they can get better.
And that was a situation where I wondered if using a long-acting and a short-acting transition was a possibility.
Well, we can also, the New England Journal article on how do you treat benzodiazepine dependence, there are 2 schools of thought. Do you want to just be miserable for a month and think about doing inpatient? Pedja and I, Dr. Gligorevich and I had a patient who was both depressed and dependent on benzodiazepines and failed TMS, because I'm also the director of transcranial magnetic stimulation program, and went to ECT. Her mood got better, but she still wanted her benzodiazepines, but she had to stop them for ECT. So it's literally this. But we moved her from a short-acting to a longer-acting, and she's slowly going down. And really, the literature is that people are not likely to get off of these. But can we move them to lower doses and less hazardous and continue to try to chip away at it? Harm reduction. Well, I have one more question.
Is there any move to, since we've got the Stop Act for opiates and all that, with benzos and pharmacy plans encouraging the 3-month prescription supply, and the patients wanting that, how do we, the benefit plan is going to be asked to change?
Well, if I had a magic wand and could wish this on people, I would say yes. But the community and the culture, you are all, my people, because you're here at this talk, or you're here today learning. So you like to learn new things. And we would like to disseminate and teach all your neighbors and teach all the people who own the insurance companies that there is some positive thing towards protocol and harm reduction and using the evidence in the literature. So plans could limit the number of different kinds of benzodiazepines. Would be a good idea.
Already, a lot of the Medicare Part D do not cover them at all, and they'll pay for them out of pocket. So it's going to have to stop at the prescriber level.
And when they pay for it out of pocket, some of the cheaper ones include Oxazepam and Diazepam, the longest acting. So now we get to do lunch, right? Thank you. Oh, and I do want to put a plug in. We're going to send you a copy of a letter that will go to the Secretary of Department of Health and Human Services to add more products to our portfolio for buprenorphine. Because if you believe in medications and you think that people need dopamine, I didn't hear the entire lecture this morning because I came in a couple minutes late, but people in withdrawal have very low dopamine levels, even with benzodiazepines, if you're acutely in withdrawal. It's very hard to think. And if you believe that medicines help you think and that we can stabilize somebody, like treating diabetes, are we better off with a safe medicine? Or are we going to send them out with nothing, no evidence? Because we know every person we discharge from our hospitals after they've been there for endocarditis, osteomyelitis, long intensive care units, every person that's on no medicines and they have opiate use dependence, less than 3% will get connected to treatment. If they're started on medicines, assisted treatment, 75% get connected. So you want 3% or 75%? And then how many times do people have to quit smoking? I've had 40. Sometimes they do it right away. Half the people do it on their own. But we have to stay with them. So we have treatments that work. We just have to get our community and educate our students. So the good news at Wake Forest is this year we had 45 students go to the student government and ask for a special interest group in addictions. And then they've recently gone to the dean and asked the dean to add in addiction education and pain education to our curriculum. I've been trying to get that there for years, but if a student asks, and 45 of them, now we're rocking. And we just submitted an application on Wednesday for an addiction medicine fellowship because we will be the only one in the state between here and Florida that will begin to train doctors for the treatment of addiction. And Dr. Brown is one of our faculty. I'm fortunate to say that. So we just need to get more people interested in it. And I do know that we didn't offer a fellowship last year, but I do know that a lot of the residents and people, not just in psychiatry, surgeons, pediatricians, neonatologists, people are really interested in infectious disease. So the idea of it's rewarding. It's way more rewarding than writing. I've been talking to the surgeons about decreasing, they used to use a lot of pills. And they're happy to be going down. So it's good. Thank you for having me.